It was actually a challenging presentation to put up because many times we talk about metrics all the time, but then when you actually try to look at the clinical evidence behind them, sometimes it's not very reassuring, in that there may be great biomechanical, great FEA evidence, but that maybe the clinical evidence doesn't support a lot of the decisions that we're making. So what I was going to go over in the next 10 minutes is talk a little bit about what these important measurements are, what are some of the reference values, and then go through some of the patient outcomes. And I'll warn you ahead of time that a lot of the research on these important metrics that we all believe in is basic science research, and there may not be a lot of clinical evidence to support these. So what are the RSA metrics? So once again, as I talked about with anatomic total shoulder arthroplasty, I have my evidence-based recommendations that I believe, and also some personal thoughts that are thrown in there. This is what I believe when I'm implanting a reverse shoulder replacement, especially in revision situations. So I want to have at least 10 millimeters of my post in host bone. Ideally, I want greater than 50% seating of the backside of the glenoid base plate, whether it's on allograft or host bone, it doesn't matter. I want greater than 50% of my screws in native bone. And this is a technique or some metrics I learned from my good friend Ludwig Seebauer in Germany. With respect to version, I think there's a lot of variability with versions. I'll accept 10 degrees of anteversion to 10 degrees of retroversion. With inclination, ideally I'm aiming for 0, but I'll accept -10. And in certain difficult situations where you just want to get an implant in, I'll accept up to 5 degrees. With lateralization, I base this on the work of my good friend Bob Tasjan. I look for about 2 to 3 millimeters lateral to the inferior rim. And finally, with positioning, I'm still a very traditional reverse person. I like to place my base plate low, and I still like some overhang. So if I look at these personal and evidence-based limitations, if I can obtain those, I'm going to do a reverse shoulder replacement. And then the question is, am I going to do a metal augment, which is something I've come to like a lot, or am I going to do a bio-RSA, which is a very established technique? And this is a paper that we published recently in JSS, which was a randomized prospective study using radiostereometric analysis, comparing bio-RSA to augments. And it was interesting, they're virtually identical. So there's no the fixation with both techniques is very good. The only thing we found that was different was that external rotation was slightly better, which actually was significantly better in the bio-RSA group. And that's probably because with bio-RSA you can do a patient-matched graft, meaning that you can essentially lateralize a little bit more. And with the augments, you only have a few off-the-shelf augment sizes, so you're really adapting the augment to the patient rather than adapting the base plate to the patient, which is something you can do with a bio-RSA. So right now, both of these seem to be very good options for management of your reverse shoulder replacement. Now, if I can't do that, so if I can't get greater than 10 millimeters in both, can't get the seating, can't get the screws, then you have these options. And these are really revision options. You can do a hemi-reverse, you can do a patient-matched implant, which are becoming very popular now, hemi-arthroplasty, resection or fusion, and this is a paper that we published on hemi-reverse, and I actually think hemi-reverse is a very good option. It's a good bailout for me. It's actually worked very well. I've used it both in the primary situation and in the revision situation. So now moving along and talking a little bit about some of those specific base plate parameters, these time zero fixation metrics, and let's look at the literature. And I'm going to draw your attention to this paper, and in making up this presentation, I came across this paper, and this is an excellent paper. I recommend anybody who's interested in this, read this, because it reviews all the literature on 10 technical aspects of reverse base plates and screws. And I'm going to kind of paraphrase this for you here. So these are the 10 factors this paper looks at. It looks at all the evidence. And that's where you start to realize that there's really good biomechanical evidence, but our clinical evidence is lacking. So this paper looks at screw insertion angle, orientation, quantity, the length of screws and type of screws, so locking or compression screws. And then with the base plate, it's going to look at tilt, position, version, rotation, and design of the base plate. So I'm just going to go through a real summary of what this paper showed. So looking at screw insertion angle, so they looked at biomechanical studies and clinical studies, and what they found is that they can recommend parallel or divergent, just not convergent. And so that's something that I think we all believe in. With looking at screw orientation, they found it was inconclusive. So in those base plates that have 2 locking screws and 2 compression screws, they couldn't show a difference whether the locking screws should be SI or AP. So I think you can do whatever you feel like in that. Screw quantity was quite interesting. So they found that the greater the number of the screws, this was a biomechanical study, they found that there's a lower micromotion. That kind of makes sense. The more screws, the more fixation that you have in the bone, the less likelihood you're going to have micromotion. But micromotion is not a parameter that's directly related to failure. Once you get past a certain value, it doesn't matter whether you have less micromotion. The thing that was also interesting, they found that when you had increasing numbers of screws, they felt that there was a higher rate of acromial insufficiency fractures, so something interesting. Screw length, they found that with your superior and inferior screws, there should be a minimum of 30 millimeters, and screw type, they felt that there should be a minimum of 2 locking screws. So this is their appraisal of the literature on reverse shoulder arthroplasty, and I'll tell you, they did a comprehensive appraisal. The literature or the reference section on this paper was unbelievably long. So they looked at every possible paper out there. Now looking at base plate, they looked at base plate tilt, and they recommended, the only thing they could recommend is to avoid superior tilt because it has been associated with an increased risk of failure. Base plate position, very traditional style, keep the base plate nice and low to decrease the notching. Now with respect to version, rotation, and design, so design means, was it curved back, flat back, round or oval? They couldn't make any recommendations. So there's many different companies out there that have various different designs and sizes and shapes. So I think right now, the literature would support using any one of those. So now, what about going specifically at patient outcomes? So this is a paper, does base plate version affect outcome? This is something we talk about all the time. So this is a paper published by my friend Andy Jawa, and what he did is he looked at a large series of reverses, and he divided them up into 2 groups. So he had a group of reverses, 162 that had less than 15 degrees of retroversion on the base plate, and then another group that had greater than 15 degrees. And what you'll find is, even with greater than 15 degrees retroversion, you had no statistically significant differences between these patient populations. So this is probably one of the few papers that I could identify where we talked about parameters that then actually looked at clinical outcomes and showed that there's no difference. So although I told you early on, for me, it was really important to be between -10 and +10. The literature does not support that, so really that's a personal opinion. The literature would support we can be greater than 15 degrees of retroversion and our patients are still going to have equivocal or similar outcomes to if you're less than 15 degrees. Now, another thing that's very popular right now is the RSA angle. It's published by Pascal Boileau and Gilles Walsh. You can see it here, essentially trying to have the post of the base plate of the screw parallel to the supraspinous fossa. So although this makes a lot of biomechanical sense, and it makes biomechanical sense to me, you really can't clinically show that this makes a difference with respect to final patient outcomes. The only thing we do know is if we do place the base plate excessively superior, those are at a higher risk of a failure. And so what about base plate planning? So this is a revision case. This is a previous reverse shoulder arthroplasty where we had to do a 2-stage revision. So I'm just going to go through my standard base plate planning. So I tend to look at the 3D images, get an idea of the shape of the glenoid. I'm going to bring in my standard base plate. And you can see this is a standard base plate. It's probably going to be insufficient to manage this patient's bone loss. So ideally, we're going to want to do a bio-RSA technique. But because this patient, as you can see here, has a cement spacer in, bio-RSA is not an option for me. And I prefer not to use allograft. I prefer to use autograft if I'm doing a bio-RSA. So what I want to try to do is maximize the backside surface contact. So I went up to a 29 millimeter base plate. And in this particular case, I'm going to assess the axillary here, and I can see that in this case, the augment's pointing posteriorly. So I should really rotate it so it's going to correct that superior defect. So I'll go ahead and rotate the augment. And historically, I've always said, -10 degrees, so maybe -15 is okay now of retroversion. And now with inclination, I think with bone loss, I really make an effort to try to get it at 0 or -0. So here we're going to switch it down to 0, and then I'm going to medialize. And I'm looking for greater than 50% is the absolute minimum, but if I get 70 to 80%, that would be better. So here we get up to 80% backside seating. But because I had to ream to go medial, because there's only one size augment here. So I had to adapt the augment to this patient's particular deformity, and I've had to medialize, so then I want to get back lateral, and the only way for me to get lateral using this augment is to use a lateralized sphere. So in that case, I'll go ahead and lateralize based on the sphere. Now, if you had a patient-matched implant, you wouldn't have to do that. You can place the base plate exactly where you want to and backfill it with 3D printed metal, or if you had a bio-RSA with good quality humeral head bone, you could do the same. Place the base plate exactly where you want to and backfill it with good quality bone. So in summary, what I found when preparing this paper, so I think that thank Manos and Manos for actually getting me to look at this, is that there's many metrics out there, and many of the metrics that I quote or you quote are based on biomechanical literature, but they may not be based on good clinical outcomes. So I think the future is certainly to investigate these metrics and determine, do they actually make a clinically important difference? Thank you.